Hello, everybody. So I got this message from my mom, actually, who sent me a video and was saying that she'd be interested in my thoughts on it. And um, I started watching the video and thought, this might actually make a really good education tool because it has information here. It's a video that, right off the front, I'll tell you, is kind of critical of the COVID-19 response that we've been seeing in the United States. And there are just some really good educational points to make in this video. So I figured I'd do a little screen recording of a chunk of the video and use some of the points that these individuals make as sort of a learning exercise. So I'm going to play a little bit of the video, pause it, talk about it, that kind of thing. And so we'll go ahead and get started.
Over the last couple months here at Accelerated, and really talk about what's happening in Kern County with our testing, what's happening in California with the testing, and kind of an ER physician entrepreneur perspective on what's going on, and kind of what we think the approach should be going forward. And Dr. Masihi and myself have been dealing with this as you have. I'm sure you guys are working from home, you're sheltering in place, you're isolating yourself, and we want to talk about if that still makes sense. So we want to kind of take everything we've learned and throw it against the backdrop of who we are. We both have had extensive classes in microbiology and biochemistry and immunology. We've studied this for each of us 20 years, and we take everything that we're seeing today and we put that against that backdrop and say, does this make sense? Are we following the science?
So this is the first place I want to stop really quickly. So this person's introducing themselves and positioning themselves to the audience as an expert, right? And there's reason to believe them, right? So they talk about how they've taken all this coursework in microbiology and immunology, and these are really important fields right now because obviously these are fields that are important for understanding coronavirus COVID-19. Just what I want to point out, though, is that they don't say anything about having taken courses in epidemiology or public health. This is a really important point to make. So I've taught epidemiology in medical schools, and physicians are not, and this is not a knock on physicians or healthcare professionals in general, but physicians are not always super skilled in epidemiology and public health. Most medical schools include, a few courses in epidemiology. It's on the boards, but it doesn't necessarily mean that physicians do it well. And I've talked to a lot of practicing physicians and done classes with practicing physicians who wish they knew more about epidemiology. So, and public health. So, what I want to make is that physicians right now seem like very credible sources, and they do know a lot of information. Physicians do know a lot of information, but just because somebody is a physician doesn't necessarily mean that they're a credible source right now. Just because somebody is a physician doesn't mean that they've had extensive training in epidemiology and public health, which are the fields that are also important to consider when you're thinking about the COVID-19 response. So point there really quickly, just because something comes from somebody who has an MD in their title doesn't necessarily mean that they really know what they're talking about for this particular, COVID-19 issue and response.
We keep hearing following the science. What is science essentially? It's the study of the natural world through experiment, through observation. So that's what we're doing. We're studying the disease around us. We're making observations. We're doing testing, experiments to figure out exactly what's going on. And so this has caused some severe disruption for Accelerated as we have people coming in 7 a.m. till midnight. We're reporting to the health department. We're calling patients back. And at the same time, our volumes have dropped significantly. The hospitals, their ICUs, or the health department empty, essentially, and they're shutting down floors. They're furloughing patients. They're furloughing doctors. So the health system has been evacuated in certain places. In New York, the health system is working at maximum capacity. In California, we're really at a minimal capacity. getting rid of our doctors and nurses because we just don't have the volume. The hospitals don't, as I met with our CEOs twice in the last week, and we don't as well. So we're busy with paperwork for COVID, and we're all focusing on COVID. And so one of the things I'd like to talk about is when I talk to ER physicians around the country, what's happening? Well, because COVID has become the focus, people with heart disease, people with cancer, hypertension, and various things that are critical are choosing not to come in based on fear. So what that's doing is causing the health system to focus on COVID and not focus on a myriad of other things that are critical because we don't have the staff there. And the major component is fear. People are saying, I don't want to go get seen by my doctor. What if I get the COVID? So there is a lot of secondary effects to COVID that aren't being talked about. And so we'd like to kind of look at how we responded as a nation and why we responded. Our first initial response 2 months ago was a little bit of fear. We decided to shut down travel to and from China. These are good ideas when you don't have any facts. We decided to keep people at home and isolate them. Even though everything we've studied about quarantine, typically you quarantine the sick. When someone has measles, you quarantine them. We've never seen where we quarantine the healthy.
Okay, I was watching this video, and this was my first big red flag when this gentleman is talking about quarantine and how we've never quarantined the healthy. So, quick lesson in infectious disease epidemiology. Quarantine is the term that's used to describe when somebody has a potential exposure to an infectious agent, and then they're kept aside from other people while you monitor to see if they develop symptoms, or while you're waiting for them to have a test to become a confirmed case. So by definition, quarantine is separating people who are healthy. And it's been part of our public health response. We quarantine people during the Ebola outbreak in West Africa a few years ago. We've quarantined people were quarantined, screened and quarantined in other previous epidemics. So this individual is saying we've never done this before, but we haven't quarantined people before. But quarantining is separating people are healthy. When people have symptoms and when people are cases, for example, this example of somebody with measles, we call that isolation. It's a different term entirely. So to say that we don't quarantine healthy people is just in itself a contradiction, because that's exactly what quarantine is. So I'm watching this and I'm thinking, I don't know that this person really knows what they're talking about. This is a big red flag as I continue watching this video.
You take those without disease and without symptoms and lock them in your home. So some of these things, from what we've studied from immunology and microbiology, aren't really meshing with what we know as people of scientific minds that read this stuff every day. So that's kind of how we started. We don't know what's going on. We see this new virus. How should we respond? So we did that initially. And over the last couple of months, we've gained a lot of data. Typically in Kern County, for instance, we've tested 5,213 people, and we have 340 positive COVID cases. Well, that's 6.5% of the population, which would indicate that there is a widespread viral infection, similar to flu. We think it's kind of ubiquitous throughout California. We're going to go over those numbers a little bit to kind of help you see how widespread COVID is and see how we should be responding to it based on its prevalence throughout society, or it's the existence of the cases that we already know about. So if we look at California, these numbers are from yesterday. We have 33,865 COVID cases out of a total of 280,900 total tested. That's 12% of Californians were positive for COVID. So as you guys know, the initial models were woefully inaccurate. They predicted millions of cases of death, not of prevalence or incidence, but death. That is not materializing.
So I want to stop it again here, being critical of the early models. So as we know, models are just a prediction with error and all that kind of stuff. But just to make the point that this person is coming from a particular perspective, seems like they might be kind of cherry picking and biased in their presentation, because the models that this person is talking about are models of the worst case scenario where we don't do any social distancing. So since we've implemented policies that are keeping people at home, etc., we would fully expect the models that show the worst case scenario of us doing nothing to not materialize. A rational person, that is exactly what you would expect. So that point is kind of moot that this person is making. So again, I'm watching this and thinking, this person seems like they might have an agenda and behind what they're saying.
What is materializing in the state of California is 12% positives. Well, if we have 39.5 million people. If we just take a basic calculation and extrapolate that out, that equates to about 4.7 million cases throughout the state of California, which means this thing is widespread. That's the good news. We've seen 1,227 deaths in the state of California with a possible incidence or prevalence of 4.7 million. That means you have a 0.03 chance of dying from COVID-19 in the state of California. 0.03 chance of dying from COVID in the state of California. Does that necessitate sheltering in place? Does that necessitate shutting down medical systems? Does that necessitate people being out of work? So that's California, and that's. I also wanted to mention that 96% of people in California who get COVID recover with almost no significant sequelae or no significant continuing medical problems. So those are important statistics for the state of California. 2 months ago, we didn't know this. So I'm going to bring it to light now because we're sharing our own data. This isn't data filtered.
Okay, so we're going to talk about these numbers for a second. So one thing that's really important to point out is this person is using bad math. They're saying that of people who have been tested, 12% have been tested positive. And then they're taking that number and applying it to the entire state of California to get their estimate of the people who have had the infection. That's a really inaccurate way to look at things, right? So who gets tested? People who get tested are people who have symptoms, right? People who have been exposed. It's not just everybody that's getting tested willy-nilly, like a random sample people getting tested. So to take 12% of the people who have been tested that tested positive and try to apply that to the entire state of California, it really doesn't make any sense. So this person, I have to believe, is assuming that their audience isn't going to be able to do those quick calculations in their head and is just going to kind of trust what they're saying.
Through someone. This is our own data. We found 6.5%, and then California has found 12%. So the more you test, the more positives you get. The prevalence number goes up, and the death rate stays the same. So it gets smaller and smaller and smaller. And as we move through this data, what I want you to see is millions of cases, small amount of death. Millions of cases, small amount of death. And you will see that in every state. And since we're talking about following the science, we're going to follow the statistics and follow the science. So I want to look at New York State. They've been in the news a lot, right? And their numbers are critical. Let's go over their numbers. Cases of COVID as of yesterday, 256,272 cases in New York State. Not New York City, New York, the entire state. But they did a total of 649,325 tests. That's 39% of New Yorkers tested positive for COVID-19. That's their ratios.
Hopefully you heard it again there, using the same weird math. Taking the number of people who have been tested and the percent that tested positive of those who have been tested, 39%, and then taking it and applying it to the entire population of the state, assuming that, which makes the assumption that the people who are getting tested are just like a random representation of everybody in the state, which is completely ludicrous when you think about it and who gets tested. So I'm not sure why this person is acting so confident and almost cocky and mocking in the way that they're talking about this, because their math is just bizarre.
It's public data online. You can all look it up. 39 of the people of the people were tested. Right.
So I haven't watched this video yet. I'm doing this in real time. So obviously the person who's listening to this is picking up on the exact same thing that I was just talking about.
If there's 20 million people, there would be close to 4 million.
Which is likely, they likely have 7.5 million cases.
So I just want to make that clarification.
Yeah.
It's not 39% of every New Yorker. It's every New Yorker who's been tested.
Right. So we extrapolate data.
I just want to make that.
We extrapolate data. We test.
We extrapolate data. So he's going to try and justify what he's saying by saying we extrapolate data. We do, but we try to be accurate in who we're extrapolating, when we're extrapolating data. And by saying that we're going to take everybody who's been tested and extrapolate that, use that term to the entire state, right? That would carry the assumption that the people who are tested are representative of people in the entire state, which is just insane.
People, and then we extrapolate for the entire community based on the numbers. The initial models were so inaccurate. They're not even.
But in those initial models, a lot of them are based off if we did no social distancing.
Right.
Is that correct? So is it really fair to say, obviously they're not as bad as they were because those were based on alternative scenarios?
And some of them were based on social distancing and still predicted hundreds.
So here we go. Right. So kind of making the same points that I was already making about the models.
Of thousands of deaths, which has been inaccurate. So in New York, the ones they tested, they found.
So to be clear, the models that he's talking about, the initial prediction was 100,000 deaths with all the social distancing across the United States, and we're at over 50,000 now. Those models were corrected when we got a little bit more information to about 60,000 in terms of what the federal government was using models from Washington. And 60,000 now seems like it's an underestimate. So the point that our models were so invalid because they were so grossly overestimating the deaths, that's false. It looks like, if anything, the models that we've been using predicting 60,000 deaths with a margin of error, of course, it's looking like those models are actually going to underestimate the number of deaths from the pandemic, or from COVID-19 in the United States specifically.
39% positive. So if that's indicative, and they tested 649,000 people, that's a massive test. That's accurate data, 39%. So if they tested the whole state, would we indeed have 7.5 million cases? We don't know. We will never test the entire state. So we extrapolate out. We use the data we have because it's the most accurate we have versus a predictive model that have been nowhere in the ballpark of accurate.
Just to clarify again, the predictive models are way more accurate than this type of extrapolation this person is doing using people who got tested as a representative sample of the entire state. Because people get tested when they're sick, because people get tested when they're exposed, because they've been in certain work conditions where they are at risk of exposure, because they've been sick, etc. That's not representative of everybody, not even close, not even close at all.
So how many deaths do they have? 19,410 out of 19 million people, which is a 0.1% chance of dying from COVID in the state of New York. And they have a 92% recovery rate. If you are indeed diagnosed with COVID-19, 92% of you will recover. So we're seeing millions of cases, small amount of death.
So just to make a point there, counterpoint here, 8% of people is a lot of people. Even if that's the right number, that tends to be that's a big number of people. But even more importantly, the entire point of looking at the death rate, we've already talked about how these numbers he's coming up with are we don't know what they are, right? Even if they're accurate, it's not the important thing to be thinking about. So what's more important to be thinking about are the number of people in the hospital at one time and dying from and potentially seriously sick or dying from COVID-19. Because that gives us an indication of where we are in relation to capacity. Right, and that's the important thing to be thinking about in terms of the healthcare system. It's not the rate of people dying; it's how close are we to capacity. And we've seen that in a city where we had a very serious outbreak, or are having a very serious outbreak in New York City, that capacity is getting reached, and that is with many social distancing measures in place. So focusing on the death rate, even based on very inaccurate assumptions, like clearly inaccurate assumptions, is again trying to make a point from a particular perspective that seems to be coming from a particular agenda.
Millions of cases, small amount of death. And the reason I'm making that point is because we're going to compare this to flu and say, is this significantly different from influenza A and B? And if not, why has our response been what it is? USA, this is a big one for us. 802,590 cases as of yesterday. We've tested over 4 million. If you guys have studied globally what's happening, that's double what any other country. Germany's at 2. I realize their populations are lower, but the fact that we were able to ramp up and do 4 million is pretty impressive, which gives us a 19.6% positive out of those who were tested for COVID-19. So if this is a typical extrapolation, 328 million people times 19.6 is 64 million. That's a significant amount.
Using this very wonky extrapolation again, that is just kind of absurd.
People with COVID. It's similar to the flu. If you study the numbers in 2017 and 2018, we had 50 to 60 million with the flu, and we had a similar death rate. The deaths in the United States were 43,545.
So, super important point to make here is that the numbers for the flu are for the entire year. Now, of course, there's going to be concentration during the flu season, and so those numbers mostly happen between October and end of March-ish, which is like a 6-7 month period in terms of the flu season. So you think about, say, those 43,000 deaths occurred over that period of 6 months for the flu. We're at 50,000+ deaths right now from COVID-19 that have happened mostly between middle of March and getting towards the end of April here. So we're comparing the same number of deaths over 7 months from the flu to the number of deaths from COVID-19 that have occurred in about 5 weeks, really, is where you've seen most of them. So that comparison, again, just doesn't make a lot of sense. And the concern with COVID-19 is that it's that fast spread and fast concentration of serious illness that could potentially overwhelm the healthcare system. Another point to make is that number of deaths for COVID-19 has happened when we've been doing all of this social distancing. We don't do that for the flu, obviously, so we don't know what those numbers would be like if we were just going about our day-to-day lives like we do normally during flu season. So again, this comparison with the flu is just, it doesn't make sense. And so again, this person is just clearly coming at this, making points that are just skewing the statistics in very irrational and weird ways in order to, it seems like, make some kind of point about how we should have been doing something differently.
Similar to the flu of 2017, 2018. We always have between 37 and 60,000 deaths in the United States every single year. No pandemic talk, no shelter in place, no shutting down of businesses, no sending doctors home.
So and then the last point I'm going to make here, and I'm going to cut this off. I mean, there's more of this. It just goes on and on and on. And like I said, I'm watching this for the first time, and I'm only this far in, and there's already, this person is already clearly way off. But the last point I'm going to make is that we have a certain capacity to meet a certain need every year from flu. And then what do you do when the concern is, what do you do when you have a pandemic that's doubling, more than doubling in terms of like a day-to-day basis the number of deaths and serious illness that you would expect, and what does that do to healthcare capacity. So it's not really a side-by-side comparison of the flu versus COVID-19. It's a comparison of what things are typically like with the flu versus what things are like when you have the flu plus COVID-19 on top of it, in a healthcare system that's not set up for that amount of extra illness and death. So that's the last point I'm going to make. And it's just to kind of to wrap this up. It's just frustrating that people who are experts are intentionally putting misinformation out, either because they're doing it intentionally or because they don't actually have the expertise they need to really understand the numbers and what's going on. I don't know what the case is for this particular individual, whether they're doing that intentionally or if they just don't, if they think they understand things